Hey, Savvy Social Workers, let's get into some Unit 2 questions. A social worker who has administered a mental status exam to an adult client would be most likely to refer the client to a psychiatrist if he observed which of the following. Okay, so we have a social worker who has already administered this mental status exam. Okay, so we're trying to figure out what is he most likely going to refer him to the psychiatrist for, like if we observed what. Okay, affective flattening, morbid preoccupations, psychomotor retardation, and signs of self-neglect are these things that we would want to refer a client to a psychiatrist for. Okay, so affective flattening is just basically a flat affect, morbid preoccupation, psychomotor retardation, and signs of self-neglect. Some of these I know like off the top that we would definitely want to refer to a psychiatrist. So I'm just going to pause this and see what the other options are. Confusion, impaired concentration, and visual hallucinations. Well, I know for a fact that because of the confusion, we're probably not going to want to send him to a psychiatrist. We more or less want to focus more on the neuro. So if anything, I would definitely want to probably send him to a neuro doctor. So I'm going to eliminate that one, especially with the visual hallucinations and things of that nature. That might be a little extreme. And then there's C, disorientation, deficient memory, clouded consciousness, and lethargy. Okay. Again, this seems a little extreme for me to refer to a psychiatrist. Remember, when we are sending someone to a psychiatrist for a psych eval, we're looking for more psych symptoms. Whenever it goes into more physical health symptoms or more neurological symptoms, then that might be a little bit more extreme for the psychiatrist. So with disorientation, would we send our client to a psychiatrist because he's disoriented? I already just look at that one word and I will rule it out just because no, I wouldn't. And deficient memory, what will a psychiatrist do about the deficient memory? So, not saying that there's absolutely nothing that they can do, but they're saying which one would we most likely refer to. So most means the one we're going to make that's going to make the most sense. And for me, when someone has a bit of a flat affect, I think that, that is more so. I know we kind of discover that whenever we're doing a mental status exam, you can kind of tell someone's mental if they're giving you a flat affect. And I know psychomotor retardation is when their mental health slows down, and it's like one of the main features of depression. So like whenever their mental or their physical movements or activities or whatever just starts to slow down, that's one of the key signs of depression. So because I know that, I think that would be something that would be for a psychiatrist, and especially signs of self-neglect. We want to send them to a psychiatrist to see, what is going on, psychologically, for them to be neglecting themselves. So because of, the majority of these like morbid preoccupations, I'm gonna be honest, I'm not really sure exactly what that would all entail, but I would choose A simply because I know that someone that's presenting with a flat affect or some psychomotor retardation and signs of self-neglect, those are all reasons I would send to a psychiatrist. And then with, like I said, these being more extreme, A just seems like the most likely answer to me. So I would definitely choose A in this case, simply because when you put all of these together, to me, this sounds like this could possibly be depression or some type of severe depression. So definitely we would go with A for this one. Next question. A social worker is meeting with a 6-year-old who was brought in by his mother for evaluation and treatment after being referred by a teacher. The social worker notices that the boy is clingy and fearful, looks scared, and doesn't make eye contact. The mother tells the social worker that she is also concerned that the boy has no friends at school. What should the social worker do first? Now, keep in mind, y'all, these are Unit 2 questions, and I forgot to mention at the beginning of the video that when we are working on Unit 2 questions, it is very important that we are paying attention to signs and symptoms, because that is what's going to dictate and determine the answer that we have to choose according to what the priority problem is. So we want to pay close attention to the questions that gives you a lot of signs and symptoms of something within them. So in this case, the social worker is meeting with, so that lets me know we're in the beginning phase of the helping process, because we're just meeting with them. And so we're meeting with a 6-year-old who was brought in by the mother. So the 6-year-old, here we are, is our client, and they're bringing him in for evaluation and treatment after being referred by his teacher. So all of this lets us know that we are in the beginning phase of the helping process. Okay, so when meeting with this 6-year-old, the social worker notices that the boy is clingy, fearful, and all of these things. So this is what the social worker notices that's going on with this client. The mother tells the social worker that she's also concerned that he doesn't even have friends at school. So being that this is a Unit 2 question, I know this is a lot going on, but again, whenever they give you a lot of signs and symptoms of something, that's where I really want you to focus on. And so even though we can say that, this is the presenting, this is the priority, we still have to understand the signs and symptoms, especially because we are evaluating this client. So some of the signs and symptoms is we notice that this child is clingy and fearful. This child looks scared, and this child does not make eye contact. Okay, so this could also be considered as your priority as well as what the mother tells you, that she's also concerned that he has no friends at school. That's another sign of something. So when we look at all the signs and symptoms in this situation, he's clingy and fearful, he looks scared, he doesn't make eye contact, he has no friends. We pay attention to that within our evaluation. So the question is asking, what should we do first? And of course, we know that first means most important. So what is going to be the most important thing we do about a client who is exhibiting these symptoms, especially a 6-year-old? So would we make a provisional diagnosis of separation anxiety disorder and get permission to contact the girls, and I'm sorry, this should be the boy's teacher for collateral information? Is this going to be the most important thing that we want to do about these symptoms? Give him a provisional diagnosis of separation anxiety and then contact his teacher. I'm gonna go ahead and pause this. A little bit of me wants to say no, simply because that really has nothing to do with what I'm noticing in the moment, what he's actually exhibiting, being clingy and fearful. It could have something to do with separation anxiety, but the second part of this, getting permission to contact his teacher, could have something to do with him, finding out about why he has no friends at school. So I am going to pause that for that reason. B, assess for the possibility of child abuse. Would we want to assess for the possibility of child abuse in this moment with these symptoms, with these signs and symptoms? He's clingy and fearful, looking scared, doesn't make eye contact, having no friends. I'm definitely going to pause that as well, because a lot of this, I know, are signs of possible child abuse as well. So we're going to pause that too. C, arrange for psychological testing to assess the severity of the boy's anxiety. Well, there's nothing really in here that really specifies that he has anxiety. We can arrange for some psychological testing, but that's not going to be the most important thing. We want to deal with what's going on in the moment. And so I'm going to eliminate this one for sure, because that's not going to be an in the moment solution. So in the moment, he's clingy and fearful. He looks scared. He doesn't have friends, doesn't make eye contact, all of those things. So do we want to make a, in the moment, do we want to make a provisional diagnosis of separation anxiety and then get permission to contact his teacher for collateral information? Is that going to be more important than assessing for the possibility of child abuse? Okay, so of course, this boy is showing signs that he may be a victim of child abuse, and it would be very important to assess this possibility first before proceeding with any other intervention, because we know that safety takes precedence, being that this specifically is going to be, um, these are signs of possible child abuse. Um, we don't want to overlook that, okay? So while a diagnosis of separation anxiety is possible, the social worker would have to first address the possibility of child abuse before focusing on identifying a diagnosis. So basically, we don't want to diagnose him with separation anxiety or whatever the case, and he is traumatized from probably child abuse. So that's kind of like misdiagnosing him. So let's deal with safety first because of these symptoms. Him, being clingy, looking scared, not making eye contact, not being able to make friends. And he's only 6 years old. So we know this is not normal behavior for a 6-year-old. So the first thing we would want to do is assess for the possibility of child abuse and rule out any safety issues or concerns first. A social worker is working with a client who reports being date raped a week ago. When would it be most appropriate for the social worker to refer this client to a support group? Okay, so we only have one sentence, which is going to be our presenting and our priority issue or our priority focus. And so the question wants to know, when will it be most appropriate to refer this client to a support group, considering the client reporting that they were date raped a week ago? So, we're going to do what makes the most sense. So would we refer this client to a support group right away so that she can get needed support? Pause. We're going to pause that. Would we refer this client to a support group as soon as she expressed her feelings about the rape? Would we want to wait till she expressed her feelings about the rape to refer her? I am going to probably eliminate that one. Okay, and see when the acute trauma reaction has subsided. So I guess what this is saying is basically when the initial shock has worn off, is that when we want to refer her to a support group? Maybe so. So I'm going to pause that one as well. All right. And what about not until she expresses a desire to join a support group? So do we want to wait to refer her when she expresses a desire? So I would not wait until she expressed her desire, because she may never express her desire to join a support group. She may be afraid. A lot of times clients don't know what to expect from these things. So sometimes they do need the reinforcement and the encouragement from us as the social workers. So as a social worker, I don't think that we should wait for the client to suggest a support group. So I'm going to eliminate that one. So now that leaves us with A and C. Either we can do it right away, or we can do it when that initial shock has worn off, okay? So I look at it like this. If we do it right away, the client may still be too fragile or disorganized to be able to benefit from a support group so early on. But once the client has stabilized, then that referral might be more appropriate. So just doing it right away, like, okay, you experience this, let me get you to a support group, that is definitely too soon. And one of the things I also know about crisis, group therapy is generally contraindicated during a crisis. And the psychological consequences of rape can lead to a full-blown crisis. So considering that this client is in crisis, sending her to a support group right away will definitely not be the most, to me, the most appropriate thing to do. The acute trauma reaction that develops initially, that may include shock, like I said, anxiety, dismay, all of those things. After they wear off, after that initial shock is wearing off or worn off, um, that's when we typically need to focus on emotional support for the client once the shock wears off. So I would definitely say that C would be the most appropriate to time to refer this client to a support group once the shock of what happened has worn off, and then they need someone to help emotionally support them through the residue. Okay? A social worker is meeting with a 46-year-old client who has been unemployed since he started having seizures about a year ago. His wife works and the family has been getting by on her income. When the social worker asks why the client has come in for treatment, the client reports that he wants help figuring out how to get a job. What should the social worker do first? Okay, so we're in the beginning of the helping process with this client. Our client is a 46-year-old who has been unemployed since he started having seizures about a year ago. Okay, so his wife works and the family has been getting by on her income. That is some lagniappe information that they're just giving us. When the social worker asks why he comes in for treatment, this is what the client reports, so that's what we want to focus on. Okay, so the client reports that he wants help figuring out how to get a job. What should the social worker do first? Okay, so in this situation, do we want to contact the client's past and potential employers? Now, remember, we're trying to do the most important thing about the client reports that he wants help to figure out how to get a job. Is contacting his past and potential employers going to help us figure this out? Absolutely not. So we're going to eliminate that. B, ask to meet with the client's wife. Okay, so is meeting with the wife going to address the fact that he wants help figuring out how to get a job? How is meeting with her going to address that? Now we're gonna eliminate that as well, okay, because we want to keep our focus on our client. C, consult with the client's medical specialist. Okay, so if he wants help figuring out how he can get a job, that might be something we would want to do, considering he's been unemployed since he started having seizures. So that means he had a medical issue which stopped him from being able to work. So before we can help him figure out how to get a job, we might want to see about getting permission to consult with his medical specialist. Or we could refer the client to a career counselor. Yes, a career counselor could definitely help him figure out how to get a job. But of course, safety first. He is unemployed because he had medical issues. So before we put him out or we encourage him getting back out into the workforce, we would want to possibly consult with the client's medical specialist, because the medical consultation, because of his seizures, is probably related to some type of medical condition. So the physician would have the expertise needed to offer an evaluation of any work-related problems that may have resulted or may result in the future due to his condition. Having this information, doing this consultation, could help the social worker and the client understand his work-related limitations and how to best navigate the issues during the job search process. So that would let us know like what kind of jobs he can do or he can't do? Can he work these physical jobs? Can he work jobs where he's standing a lot? Can he work jobs where there's a lot of stimulation in the environment? Anything like that, the medical specialist consulting will be able to give us that information. So the most important thing, because again, this is the first question in trying to meet this man's needs, would be to consult with his medical specialist to see what are the limitations of him getting the job, or if he could even work at all. A high school senior is brought in for evaluation by his mother, who is concerned because the boy is hearing voices and has withdrawn from his friends and family over the past 4 months. He has no other symptoms. What is the most likely diagnosis for this boy? Okay, so we're looking for a diagnosis, so that means automatically we got to go and pay attention to the signs and symptoms. So we have a high school senior who's brought in for evaluation, so we already know we're looking for a diagnosis. So all the rest of this is not really going to be relevant. We need to look at for his signs and symptoms. So the concern is that he is hearing voices and he has withdrawn from his friends and family over the past 4 months. So this has been going on for 4 months. He's been hearing voices and he's withdrawn from friends and family, and he has no other symptoms. So we're focusing only on the symptoms that they gave us. So the most likely diagnosis, is it schizoaffective disorder? So of course we would have to know what schizoaffective disorder is, which is characterized by an uninterrupted period of illness during which at some time there are concurrent symptoms of schizophrenia and symptoms of a major depressive or manic episode, with a period of at least 2 weeks without prominent mood symptoms. So does that sound like hearing voices and withdrawing um, from his friends? I would definitely say that this is probably a little more extreme than what's really going on here. So for that reason, I would rule out schizoaffective disorder. Now, schizophreniform disorder, what exactly, we have to know exactly what is that. The diagnostic criteria for this disorder is identical to the criteria for schizophrenia, except the disturbance is present for at least 1 month but less than 6 months. So it's just similar symptoms to what we diagnose for schizophrenia, but instead of it being for longer than 6 months, because schizophrenia, it has to be continuous for at least 6 months for it to be schizophrenia. So schizophreniform, I tell people to think of it as a form of schizophrenia, but not so much because it hasn't been long enough. So for that reason, I can tell y'all we're going to already rule out C because it hasn't been 6 months. It says 4 months. So I'm going to keep B because this could be some symptoms. He's hearing voices and he's withdrawing from his friends. Now, our other option is delusional disorder. Okay, so with this one, I will go ahead and eliminate out the gate because it doesn't say he's delusional. It says that he is hearing voices, and that is more along the lines of hallucinations. That is not delusion. So delusion is usually when you are seeing things that are not really there. So for that reason, I will rule that out. And so that leaves me left with B, schizophreniform, which is a form of schizophrenia. You're hearing voices, you're withdrawing, not really wanting to interact or engage with others. Auditory hallucinations and social withdrawal, or both found in the active phase of schizophrenia. However, because of the time span only being 4 months, that's what makes it schizophreniform. So yeah, we're gonna go with B as our answer. All right, I hope this video was helpful. I know that Unit 2 is a little different to prepare for because it is the assessment and diagnosis section. So just remember that the questions, especially the questions that are asking you to diagnose the client, you want to pay close attention to what to the time span, the time frequency, and duration of of the symptoms. And then when you're assessing clients, you want to make sure you're paying attention to what are the certain signs and symptoms, and what do you need to do about those signs and symptoms, if they're not asking you to diagnose them. So you have to be able to pull out the signs and symptoms within these questions and then address the answer accordingly. So I hope this was helpful. Leave any questions or comments you have down below. And again, I appreciate y'all being here, and let's continue to get those passes the savvy way.